Picture this. You're working a shift in a chaotic pediatric emergency department. Suddenly, the doors just fly open. A frantic parent rushes in with their young child, and you can instantly tell the kid is struggling for every single breath. Their eyes are wide with panic. The whole energy in the room shifts in a second. You know right away this isn't some routine cough or a standard cold. No, you are staring down one of the most high-stakes, rapidly deteriorating scenarios in all of medicine. Welcome to this Derskit Premium Revisions Explainer, where today we're unpacking the absolute critical essentials of acute epiglottitis. Let's get right into it.
So, you've got a 4-year-old child presenting with a high fever, active drooling, and inspiratory stridor. You know, that really harsh, high-pitched breathing sound? As a clinician, the clock starts aggressively ticking the exact second this patient crosses your threshold. What is your absolute immediate priority? Keep this question right at the back of your mind as we break down exactly what's happening inside this child's throat, because honestly, your answer here determines whether this patient survives.
Okay, to truly grasp the urgency here, we have to look at what acute epiglottitis actually is. It's an acute, potentially life-threatening inflammation and swelling of the epiglottis and the surrounding supraglottic structures. Normally, your epiglottis is just this helpful, little leaf-shaped cartilage sitting right at the entrance of the larynx. When you swallow, your tongue pushes back, the epiglottis folds backward, and it neatly covers the laryngeal inlet so food and liquids safely pass into your esophagus instead of down into your lungs. But when it gets severely inflamed, that protective little leaf blows up into a dangerous, swollen blockade parked right over the airway. Let's trace exactly how this crisis unfolds. It usually starts out simple enough, an infection or maybe an injury. But this rapidly triggers intense inflammation of the epiglottis. That leads to marked edema and swelling, which very quickly narrows the supraglottic airway, causing inspiratory airflow obstruction. And ultimately, if left unchecked, it progresses to complete airflow obstruction, which leads directly to hypoxia, cardiac arrest, and death. And here's a super crucial point to remember. Kids naturally have much smaller airways than adults, so it literally only takes a relatively tiny amount of swelling to cause severe, complete airway obstruction in a pediatric patient.
Now, because this condition moves so incredibly fast, mastering the key clinical diagnostic signs is without a doubt your best weapon. And our main focus today is exactly that. The absolute hallmark here is the classic clinical triad. Memorize this: sudden fever, drooling, and stridor. But the presentation usually extends even further. These patients are going to have a severe sore throat accompanied by dysphagia, which is difficulty swallowing, and odinophagia, which is painful swallowing. Because swallowing hurts so intensely, they just stop doing it. And that's exactly why you see the active drooling. You're also really likely to hear a very muffled voice. In medicine, we often describe it as a hot potato voice, kind of like they're trying to speak around a giant mouthful of scalding hot food.
Often, when you walk into the room, the visual alone gives away the diagnosis. A child with severe epiglottitis will instinctively adopt what we call the tripod position. They'll be sitting upright, leaning forward, neck extended, mouth open, and their tongue is often sticking out. They are utterly terrified. Why? Well, this is a desperate biological attempt to maximize their airway patency. They're literally using gravity and body positioning to keep that swollen epiglottis from falling backward and sealing off their breath. And the golden rule here? Do not, under any circumstances, force the patient to lie down. Doing that can instantly snap the airway totally shut.
Which brings us to a classic examination trap. You have a child in respiratory distress with stridor. Is it epiglottitis or is it croup? We really need to firmly differentiate these two. Epiglottitis is typically bacterial. It hits with a rapid onset, features a high fever, prominent drooling, and notably, pay attention to this, the cough is usually absent. Croup, on the other hand, is usually viral, has a much more gradual onset, a low-grade fever, mild or even no drooling, and it features a very distinct, harsh, barking cough. So your major diagnostic formula is this: child plus high fever plus drooling plus stridor plus absolutely no barking cough equals think epiglottitis.
All right, instinct check. As a medical professional, your very first instinct when someone complains of a severe sore throat is to grab a tongue depressor, pop it in, and take a look, right? Well, if you suspect epiglottitis, do not do this. Actually, scratch that. Don't even go near the throat. Forcefully inspecting it with a depressor can agitate the child and actually trigger a laryngospasm. That's a sudden spasm of the vocal cords that results in complete, irreversible airway obstruction. In this scenario, securing the airway always takes priority over getting a visual diagnosis.
Now, if the patient is totally stable and the airway is completely secure, you can start considering investigations like a full blood count, cultures, or imaging. If you do get a lateral neck x-ray, you might spot the classic thumb sign. This is where the massively swollen epiglottis literally looks like a human thumb pushing out into the airway space. But let me be absolutely crystal clear on this. You must never, ever delay airway management just to get this X-ray. It's a neat radiological finding after the fact for sure, but it is not worth risking a patient's life over.
So, how do we actually handle this? When it comes to management, remember, this is an airway emergency first and foremost. You trigger the ABC approach immediately. Airway, breathing, circulation. Call for your experienced airway personnel, keep the patient as calm as possible, and give oxygen if they'll tolerate it. The next priority is protecting that airway. If there's significant obstruction, endotracheal intubation is required, and that needs to be done by an experienced clinician in a highly controlled environment with backup standing by. If intubation fails, you have to move to an emergency surgical airway. Once, and only once, the airway is locked down and appropriate cultures are drawn, you start intravenous antibiotics like ceftriaxone or cefotaxime to knock out that bacterial infection. To really lock all these high-yield examination points into your brain, you can lean on the epiglottitis mnemonic. It's an emergency airway situation. There's painful swallowing, inspiratory stridor, and a generally high fever. You'll see them leaning forward due to obstruction, you might see a thumb sign on an X-ray, and you should always think HIB. Intubate early because that sudden progression is incredibly unforgiving. Memorize this framework and you'll literally have the entire clinical picture ready to go at a moment's notice.
Oh, and I mentioned think HIB a second ago. Historically, the main causative organism for this absolute nightmare of a condition was Haemophilus influenza type B, or HIB. Today, though, the incidence of HIB epiglottitis has plummeted, and that's thanks to one massive preventative tool, routine childhood HIB vaccination. Knowing this historical context, the preventative measures, and exactly how to manage the acute crisis, that is exactly the kind of comprehensive knowledge you need to excel in practice. Utilizing focused clinical resources, like the OSCE stations and classes from DERCAT Premium Revisions, is just a fantastic way to master these high-yield scenarios for your exams.
So, we return to our starting point, the 4-year-old in the emergency room. The airway is now secure because you knew exactly what to look for. But in medicine, you know the clock is always ticking, and the next emergency is probably already coming through the ambulance bay doors. The real question is, will you be ready to recognize that classic triad of fever, drooling, and stridor before the airway completely closes on your next shift? Trust your clinical diagnostic skills, respect the tripod position, and never force a patient onto their back. If you found this case study valuable and want to keep elevating your clinical game, definitely check out the full range of programs over at DERCAT Premium Revisions. Stay sharp out there, keep learning, and I'll catch you in the next explainer.